ABDM best practice, HFR in the state of Andhra Pradesh. We all know the HFR is one of the milestone in our ABDM. So we Andhra Pradesh, not top, but we are one of the best state across all milestones or all modules. You may call HPR, HFR, EHR, and ABA and all. So we always face one problem that we are not getting 100% HFR. So this always troubles me why we are unable to take 100% in HFR. Then we analyzed the data and we came to know that we are having NHA is showing lot of numbers in NHRR, and in field it is not there. So we keep on telling the team that the numbers showing are not originally reflecting in the ground, hence we are unable to do 100% HFR mapping and all. So it's keep on think tank, and later we came to know that lot of discrepancies are there in the list.
Dr. Rao, your slides are not visible.
Yeah, I'm not going there. I'm just introduction. So then we analyzed the data and we came to know that there are discrepancies in the HFR. So we worked out and we have taken it to the notice of the NHA, and NHA is kind enough to modify it. And finally, we concluded the original data and actual data. These are all due to different reasons. నువ్వు చెప్ రన్ చెక్ సో రన్ చేయాలి నెక్స్ట్ స్లైడ్. So this is what total 43,146 NHRR data with approximately 23 facilities marked as pending in HFR registration. In practical, in our state, there is no 23,000 facilities pending. So we have taken it in deep dive it, and we came to know that there are a lot of general stores. The key issues identified is general stores and non-health establishments incorrectly included in facility registry. This is the one of the reason. And the second reason is subcenters with valid facility codes still continued as pending registration. We have already subcenters in government subcenters, that is health and wellness centers and all. We have HFR valid number, still some of them are showing as pending. And third is duplicate entries from multiple data collection periods. So what it is, some PHE in the name of abbreviation form and another PHE is in, and when the facility manager changes, they don't know that HFR is having, again they created another HFR with another number. Since in the data there is no restrictions, they can simply one time Satyanarayanpuram, another time SN-puram, like that they created. So improper naming conventions preventing accurate facility identification. These are all the reasons. Then impact of matrix is inflated denominator artificially reduced HFR saturation percentage. So we already did it, but because of high denominator or always our percentage is less. Then true implementation progress was obscured by data quality issues. Approximately 23,000 pending registrations were largely non-actionable duplicates. Actual valid facility count significantly lower than reported NHRR figures. So this started from the October 23. Then we in May 20 to October 24, we find it all these. Later we have taken all the comprehensive data validation, cleaning, cleansing and all. initiative taken by our team. So later we came to know that. Next slide. These are all clinical establishment reality. Actually, instead of 43,146, these are all the facilities currently we are having. According to clinical establishment data in our state, we are having 9,000 plus private facilities and 13,000 plus facilities in public facilities. Total it not greater than 25,000. But whereas this represents discrepancy of almost 18,000. So compared to 43,000, it is more variation. So we take up as cleansing. So this is the original NHR data shows left side, that is 43,000. Out of that, government is 13,000. Private all put together, they are showing NHR data showing 30,000. Whereas in government, we are having on board 19,000 and private is 8,535. So later we also find more, but I will come later on that. So NHR data was originally collected from the Minister of Health and Family Welfare in 2017-18. From the states, it is 6 years old. Significant data quality issues are there, including duplicate of government facilities, private facilities that are no longer exist, and existing private facilities missing from NHSR. Actually, there are private facilities, but it is not reflecting in NHRR. So due to these discrepancies, 100% saturation is not achieved against outdated NHRR baseline. Yes. So then what we did is planning and process. NHR data was systematically segregated into government and private facilities with 100% HFR completion achieved for government facilities. So when we completed HFR 100%, we came to know that a lot of government facilities are duplicates are there. We removed all government duplications and we shared it across all facilities that this is your HFR, era for not to create HFR again and again. What happening is, in NHM, in RCH2, they don't know subcenters. They're again creating an HFR. So that leads to duplication of government facilities. Then what we did is zonal and category analysis, facility-wise, divided zone-wise across the state systematic verification. Each facility underwent detailed analysis and categorization based on data quality, parameters, and operational relevance. Then quality assessment, comprehensive identification of irrelevant entries, duplicates, and data inconsistencies was conducted through ground level verification and cross referencing with multiple data sources. What we did here is we have taken different databases of our IT system. What actually in EHR, actually every day they are doing EHR now. So we have HFR in EHR with compared with all the government portals, Government of India portals. So Nikshaya and immunization and RCH, all these duplicates was removed, and finally EHR data, HFR is given to them. These are all the detailed breakdown of facilities, how the data quality issues arise. Total duplicate entries, double entries are 4,310, and a facility name not proper. So name not proper comes under almost all it is 1,055. Not a health facility, but it's shown as a health facility. So those are all general stores, but marked as pharmacies. These are all not pharmacies, but these are all only general stores. Then the same facility repeated, 798. Person name used in some institutions shown it as it is not health facility, it is individual name. Individual name also shown in the NHR data as health facility. And there are all first aid centers. Some first aid centers are there. Those facilities also shown as health facilities. And new facility name, there is no names, but shown as facility 206. So RMP names 190. Some RMP practitioners, they put as doctor. They don't have any degrees and all. These are all 190. And undefined names 142. Anganwadis also comes under as health facility. Those are all 47. All these combined. All these 8,433 removed from our NHSR data. What happened? Up to that, our percentage is 43. Once the cleansing is over, our percentage of HFR creation against NHSR data has increased to 70%. Next slide. This is 45 to, before cleansing, it is 45. After cleansing, it is gone up to 79. Previously, our rank in HFR is almost all 16 like that among all states. Now it is came to sixth place. So still, recently we identified that there are a lot of institutions still in the field, but are not reflecting NHR. So now what we have taken up is, though it is not in NHRR, we are recently started, that was not included here, but we are doing already. And last 2 months, we have registered 2,000 facilities, which are neither in the NHR data nor in our database. But reality, there are existing in the field. That is also taken up because that was not concluded. I am not included in the presentation, but I am telling this, revealing this to the states. You also can easily identify it once you visit the districts. And what I am doing is, particularly these are all in the field of pharmacies, because the pharmacies are easily movable. They can move from here to there, and they can close the pharmacy and they can reopen somewhere else in somebody names. So these are all subject to change pharmacies. What I did is, I have taken a joint meeting with the Drug Control Authority of Andhra Pradesh, and each district they are having assistant director drug control. I have taken Zoom meetings, and we have created health facility verified to all the drug registration department assistant directors, and they are doing their facilities registration instead of our DGMOs. We have given to them only because they know the pharmacies, and they are the licensing authority, and they will easily register these all pharmacies. So one or two of our districts, they did even within 8 days, they completed almost 2,000 pharmacies registration. One of the assistant director completed. He is in charge for 2 districts. What we did is, we recommended for Republic Day Award for that assistant director. And now all other districts in our state, they are also coming forward to register. And after 1 month, our HFR data will surpass not even 43,000, even it may increase more. So what I want to say all you is, next slide. This is the duplicate identification, how we did it. And standardization, how we did standardization is, for each PHE, previously what happened in duplication, they created like SN Puram PHE. Somebody created PHE SN. What we did is, we rationalized it. First PHE name will come, then the facility village name will come. So PHE SN Puram, in any PHE, starting with PH. Likewise, UPHE name, CHE town name, district hospital with city, general hospital with city, and sub-divisional hospital, that is here in our state, area hospital with city. Like that, we standardize the names. So hereafter, nobody can create facilities on their own. So whatever we created, that is final, and the name will come in that line only. If anything comes reverse, it will go. So we will not approve that in the login. So this is standardization, naming convention we have taken, and district-wise uniqueness. Government facilities were made district-wise unique. Duplicate HFR entries were systematically deactivated, and one official HFR code was finalized per facility that was given to them and asked them to paste it in their facility prominently. Hereafter, even the facility manager changes, so he will easily came to know that they are the facility number and all. So the master data set creation was created. We are maintaining for all government facilities, and we are making all dashboards with this HFR only, no other. So only this HFR we are identifying the HFIR for data analysis and all. This is under process. Our IT team is taking care of that. This is from our sustain. The key takeaways is you should identify root cause, identify your problem. Our problem may not be your problem, and some may uh, match, but all may not match. You have to identify your root cause, and you have to take proactive state action, because at the NHRR review meetings, the HFR percentage saturation was taken lagging our rank. So our authorities has asked me and made me responsible. Then being a nodal officer of the state, I have taken proactively, and our team, ABDM team, entire team and IT people all are worked hard, and they have taken day and nights for each facility, 19,000 facilities, they changed the names, HFR names, because for uniqueness and all. So I request here NHA also, in the website they are creating as they like. Instead of that, you can put a filters. Only the facility name first and the town name later. Like that, filters you may kept it for creation of uniqueness in the database. Since it is not there in the data provision, we have created. We have taken all these steps. These are all few things we did from Andhra Pradesh. I hope it may help you. If you have any queries, questions, you may ask. I request you ask in English only. Some of you may take in Hindi, so you can ask in English, anybody. You are welcome. So as Andhra Pradesh, we have another problem, because what happened is our state has bifurcated in 2014. Some of our data in the both Telangana and Andhra, Telangana, they are taking all new registration their denominator, whereas here in our councils and our all NHSR data, they are the unified state data is taken to NHSR. That is also one of the reason in our Andhra Pradesh. And we are now working in denominator part of both HFR and HPR. Within 1 week time, we will also, as per the NHA COSR directions in the Bhubaneswar meeting, we are shortly going to communicate our Kiran sir and CO sir has asked us to fix the denominator part for HFR and HPR. Our team we are all working on that. Within no time, we will communicate to the NHA team. This is all from my side. Over to team. Nobody is asking any doubts or queries. It is to team. Abhiday, is it okay? Abhiday and Jayant, you are not audible. You are in mute.
Okay. Sir, can you hear me now? Am I audible?
Yeah, I am here. Abhiday.
Okay. So Sahil has a question, sir. He will continue.
Yeah, sorry, sir. We were just muted from our end. Just one comment, question here. Sir, I think you had mentioned about the drug control department that you guys had partnered with them for understanding the number of pharmacies in the state, right? If you could just talk about that process, sir, because again, from NHS and we've just been trying to understand the entire universe of pharmacies in the country, and this is a great roadmap for us also to just, from a denominator perspective, see how we can incorporate that. And so, just one last point here was, I think, and we've been doing this through the State Adoption Index activity. The Ministry of Health and Family Welfare, they had released a report called the Health Dynamics of India report for 22-23. In that, they've detailed out in the proper bifurcation that you had also mentioned earlier for all government facilities. They've detailed out at the CHC level, PHC level, district hospital, medical college level. So I think that will also be a great data set for you to just corroborate your data with, because you've done that for NHRR through deduplication for government facilities. And if you can just map that with the Health Dynamics of India report, because it's a recent report. Yeah. Thank you.
Okay. We will do that. So, do you want again to speak on that?
Yeah, so if you can just talk about the drug control department partnership, how you went about that would be quite interesting. Yeah.
What happened is, out of the 43,000 facilities of Andhra Pradesh, most of them are non-functional relating to pharmacies. So what we did is, we have verified all these, and those are all not existed, and we removed that with requesting you to delete from NHSR. But in practice, in reality, there are all more pharmacies in the field. So how can I know the pharmacies and all? So we approached our drug control department in Andhra Pradesh. So for each drug district, there is a district head, additional assistant director, drug controller. So he is the licensing authority of that district, and he knows, he inspects, he conducts raids and all. So he has more control on the pharmacies. So what we requested them is, we asked them to register all the pharmacies. Then they have to, it is coming to our DM login in the district. And our people do not know whether the pharmacy are there or not. If it is health facility, they know, because they are maintaining the Clinical Establishment Act. So when pharmacies are coming, they are nowhere concerned, and they don't have any authority over the pharmacies. So what I did is, we created all the districts assistant director, drug control authority as a approval authority, verifier. So verifier and approval. So immediately what they did is, they asked their pharmacies to register. For that, what we did is, we have 2-3 rounds of Zoom meetings with the drug controllers of the districts and our ABDM team. So we guided them how to create, how to apply, how to fill, how to upload photos and all. Finally, we created a video and we shared it in their group. We created a WhatsApp group for their entire district in charges, and we keep on posting in the group. So 2-3 districts completed within 1 week. They created 3,000 HFR. It is so far 5,000 pharmacies onboarded within, I think, 1 month. 1 month. And next 1 month, we hope we will do more. And our actually what we objected is 43,000 are not there. Actually, number is more than 43. So now we came to know that lot of number is there. We are doing, but those are all actually in the field exist. So even NHR data is also neither not correct and it is not tallying. So don't depend on NHRR. It is better to verify facility wise. And we are also doing the same with the Clinical Establishment Act also. We came to know that under 5,000 facilities are there. That also we are every day monitoring. Every week, today only in the morning, I have a Zoom meeting with our DMs of all districts. We have given timeline to them to ask all private facilities to create HFR within 10 days. So we hope by month of February end, we will complete both private and government at a large.
Thank you, Dr. Rahul. Thank you.
Yeah.
So, on the NHRR data which you were discussing, I think our colleague Harshit has some queries.
So thank you for the presentation. The question is largely with regard, there's a twofold question. First is that in one of the slides you had shown Anganwadis also. Could you please talk about whether NHRR considers Anganwadi and why was it mentioned in your slide? The second thing is in your own initiative, you've said that NHRR is a data that the states cannot rely on or the union government can't rely on. What do you think is a better data? And if there is any line listing process that you've started, if you could share some insights on that as well.
Okay. Actually, in the analysis, it came out that there are 47 Anganwadis. Anganwadis are the Women and Child Welfare Department institution. It is not a health facility. It is there in NHR or data of Andhra Pradesh. It is there. Now you may remove it after our email, and these are all removed by your team. So all these 8,433 were removed. Previously, it was there. So I did. Why it may be now? It is not government of India fault or something else. The data may be given by what happened. I'm working since 25 years in the department. I worked as a planning assistant director in 2005 to almost 12. In that times, Minister of Health and Family Welfare repeatedly every year asked the list of facilities of the state for the NHSR, NHSRC, or now it is NHSR, NHRR. So what happened? We used to call it from the districts. So in the districts, it is pertinent problem in the field. Nobody continue in the same place. So we push them, ask them, we fix target, date and all. So what they will give is, they will give their own. So by the means of all these false data only, it came to creep into the NHRR data. So it is the fault of the states only, finally reflected in NHRR. So the data of NHSR is given by the states once upon a time. So all these come, and pharmacies and all, because of some may removed, some may closed and all. That is due to non-existence. And the health facility duplication came because of RCH2. What happened is, in RCH2, all facilities should give the HFR. So the present officer working in the health facility, maybe the MLHV, that is CHO, may not know that already the subcenter is having the HFR. So again they created. So due to that, duplication came. So all these came found after analysis only. So these are all the reasons for that. So different surveys, different councils, different source, it all came to the NHRR. So now it is our duty to revamp and give a detailed data. So once we all the registration complete now, we will give it to a data set with that uh, with that with the denominator and along with the standardization. What we did is, this is from my side.
Okay, thank you, Dr. Rao.
Yeah.
So I believe all the queries have been resolved, or if any state is having any query related to the PPT, you may please ask. Okay, thank you. So for the next presentation, I would like to invite Dr. Rajni BN, Director Medical Management, Suvarna Arogya Suraksha Trust, Karnataka.
Good afternoon, everyone. Am I audible?
Yeah, audible.
Yeah, thank you so much. Thank you for giving this opportunity to the state of Karnataka for making a presentation on the best practice.
Thank you, madam.
Yeah, I'll be sharing the slides. Yeah. Okay, I'll make it slideshow. Just minimize this. Yeah, okay. So my presentation will be on one of the procedure which we have brought in under the our ABPMJ ABRK scheme, that is the scoliosis. Hitherto, we have 1,650 procedures enlisted under our scheme. And scoliosis is one problem which was, the procedure which was not found in our ABRK scheme, nor was it there in the RBSK scheme. Understanding the problem and the prevalence of scoliosis, just to brief, globally it is estimated to be 1 in 1,000, and 2 to 3% of the general population in India could be suffering from scoliosis. And scoliosis is the leading cause of physical disability, which affects the adolescents mainly of 10 to 15 years. And this is one age which would be a future productive age group. And it is understood that the incidence is also high in males. Yeah, and it's been found in certain studies, and it is also, there is a regional variation. So the spinal deformities, be it scoliosis, kyphosis, or lordosis, physically, anatomically, physiologically, it can lead to a lot of progressive pain, neurological impairment, respiratory complications, and permanent disability if not treated in a timely manner. And corrective surgery is the only definitive intervention to halt the disease progression and restore the functional ability. The problem with scoliosis is that the lack of awareness and also the screening. And it is understood that early detection to prevent the progression is the key factor. The treatment modalities are, it depends on the stage. Maybe it is observation in cases which are mild. In severity, it may be bracing, physical therapy, and exercises, or surgery. Surgery is one which is multi-dimensional, in the sense it is highly skilled, requiring multiple speciality from the orthopedician's part, the neurologist, neurosurgeon's part, and also the pulmonologist's part. So understanding this, and also that the high cost and complexity of this spinal deformity corrective procedures, it places a significant burden on the patients. As we understand, as I already mentioned, the lack of awareness and also the screening part. Many people or many may be under the impression that once set in, it cannot be corrected. But once it is early detected and through proper screening procedures, then definitely something can be done to improve the quality of life of these children. So understanding this, before we got it into our scheme, there is one organization who was exclusively working for scoliosis, and they had an MOU with RBSK, and they were doing free of cost. So it was at that time that our principal secretary, whom they approached, they said they are doing it free of cost. And under our scheme, where we have the SAST TMS portal, since they were doing free of cost, we brought in another tab. We made provision for these charitable hospitals, and we started getting the data of those children who were operated under this free scheme, where it was costing nothing to the government and the NGO was bearing it. Then later, once the MOU got over, it was decided that this physical deformities, that is scoliosis, lordosis, or kyphosis, needs to be brought into our scheme. And that is where one government order was issued in the month of February of last year. This package aims to ensure equitable access to essential specialized treatment to prevent long-term disability, improve quality of life, and reduce future healthcare expenditures which are related to the pain and hospitalization and secondary complications. So that was the need when this scoliosis was brought under unspecified surgical package. Expert committee was formed, which had representation from both government and private hospitals. As I already mentioned, there was one private hospital who were exclusively working on this scoliosis. So we brought in both experts from government and private, and we developed the online referral system. We already have this system, which is a gatekeeping mechanism, a check mechanism, where anything and everything cannot be approved. So the expert committee, comprising of 5 special experts, the committee sees the cases which are referred through this online referral system. They scrutinize the cases. So it is not that some hospital decides, okay, let us operate on this case. No, it is, since it is a representation by both government and private, the details of the case are scrutinized in this committee, and the committee decides the fitness of the case for surgery. So these cases are referred from district and taluk hospitals, and these are scrutinized in the committee, and the cases are allotted by the committee itself to the hospitals, both private and government. I'll just take you through the next slide. Till now, we have 5 government hospitals and 4 private hospitals who are empaneled to perform these surgeries. We do understand that this is a highly skilled procedure. It requires a lot of infrastructure and a proper monitoring system also. That is why we have empaneled right now 5 government hospitals and 4 private hospitals who have this infrastructure and who have the capability of operating on these cases. Till now, we have conducted 15 spinal deformity corrective surgeries and in the government, and 34 cases are performed in private. Obviously, we understand that private hospitals are far ahead, but still now we are in the process of empaneling more and more hospitals. Out of the government hospitals, majority of them are in Bangalore only, and only one is outside Bangalore, that is in Bellary. We are in the process of empaneling more and more hospitals with necessary infrastructure. Right now, we have another waiting cases of 9 cases. You can see in this slide, it really makes a remarkable difference for a child who has been suffering from scoliosis. Scoliosis is the lateral bending of the spine. You can see on the left and the right, before surgery and after surgery, what a remarkable difference it makes for the child, and who will be able to cope up in the future life with adequate quality. So we have shown some three or four cases, which shows the difference pre-surgery and post-surgery. So for the purpose of budget, since it has been brought under ABRK, the amount available under ABRK only is being utilized, and hence this is a sustainable model. Medical college hospitals are coming forward for getting empaneled, so that's a good thing. So in coordination with both government and private hospitals, the existing system is being strengthened, and we are able to provide care to these children in need. With this, the children would be will be confidently living a normal life in future post-surgery. So way forward, just before that, I would just like to throw light on some points. That is, after the committee was formed to include scoliosis, the rate fixation was done in consultation with these experts only. It is approved at 1.5 lakh for private hospitals, and we pay 75% for the government hospitals, which comes to 1,25,500. So the way forward is, as I already mentioned, the basic thing which has to be addressed is early detection and screening. So this can happen only with the support of RBSK teams. So now the next step, what has been taken in our state is that some of the NGOs have come forward to tie up with RBSK, to have an MOU with RBSK, so that they will support these RBSK teams in guiding these teams in identification of these scoliosis cases, so that they are identified at the earliest. And those cases which are diagnosed with scoliosis or whatever, any other deformity, spinal deformity, they will be referred. Right now, I mentioned it is through the taluk hospitals and the district hospitals. What we have done is, we will be now getting it done through the DEIC team of the RBSK, which are functioning at the district level. We are going to give them credentials. So that district DEIC team, the manager or the pediatrician, will be made responsible to refer these cases online to the state scrutiny committee. And the state scrutiny committee, after examining these cases, deciding on the fitness of the cases, will allot these cases to the government and private in the ratio, the capability which they have. For example, if a government hospital like Sanjay Gandhi Hospital has the capacity to do 10 cases per month, but there is a private hospital which is capable of doing 30 per month, then we don't give all the cases to private. We allot the cases so that every facility which has the capacity to do, based on that capacity, we are allotting the cases. We want to ensure that the child's problem is addressed timely. So we are working in coordination with RBSK team, and we hope to achieve more progress in this. So this is what I was mentioning, and this is the plan and way forward. Thank you.
Thank you, madam. So I request the states to raise your queries if you have any.
Madam, I would like to ask you, at district level scrutiny is done by the committee.
Sir?
At district level scrutiny is done, or state level scrutiny is done of a patient?
At the state levels. The committee sits at the state level.
Okay.
Every week we do the scrutiny. In parallel, we are also doing the TKR, THR scrutiny also. So simultaneously, we take up the scoliosis cases also. Scrutiny is done at the state level.
Okay. What are the who are the doctors who go for scrutiny of the patient?
We have representatives from Indira Gandhi Institute. then Sanjay Gandhi, Bowring, Victoria, and Mahavir Jain Hospital right now.
Okay. There must be orthopedic surgeons and neurosurgeons, I think.
Yeah, we have both of them.
What are the investigations done for the assessment of a patient?
Yeah, we ask for MRI scan whole spine, CT scan whole spine, X-ray, and then pulmonary function test.
All these things are done free of cost.
Sir, wherever in Karnataka, we have the CT MRI scheme of NHM, which is being done. So wherever the facilities are there, the children are subjected to these, and most of them are in district hospital or in the medical colleges, but it is done free of cost.
Madam, would like to know the age of the smallest child operated for scoliosis in the scheme.
Just a moment, sir. Do you have that? 2 years. 2 years.
2 years.
Yes.
Thank you, ma'am.
Thank you, sir.
Thank you. Any more questions? Okay. Thank you, ma'am. It was
Thank you.
really
Thank
a
you,
wonderful
everyone.
presentation and
Thank you, everyone.
really new case. Thank you. Thank you, everyone, for joining with us.